Good evening, everyone. A very warm welcome to all of you. I, Dr. 𝗂𝗂𝗿𝗍 from Team Voice of Healthcare, welcome you all for our today's session on cognition and balance, the hidden neuro-vestibular axis in clinical practice. Cognition and balance are more deeply interconnected than often recognized, linked through a complex neurovestibular axis that influences both spatial orientation and higher brain function. And understanding this hidden interplay is essential for clinicians that aim to deliver more holistic and accurate patient care. We are privileged to have with us an esteemed panel of experts who will bring deep clinical, academic, and global perspective to this important and evolving area. Let me just begin by introducing our distinguished speakers for the day. It is my distinct privilege to introduce our first speaker, Dr. Anirban Biswas, a highly respected and pioneering neuro-otologist based in Kolkata. With over 3 decades of experience in therapeutic and diagnostic neurotology, Dr. Biswas has deep expertise in managing vertigo, balance disorders, hearing loss, and tinnitus. He is the Director of Neuro-Otology at the Institute of Neurosciences, Kolkata, and founder of the Vertigo and Deafness Clinic, a leading center for vestibular and auditory disorders in India. He has also served as president of Association of Otolaryngologists of India and the Neuro-Otological and Equilibriometric Society of India, reflecting his significant contributions to the field. Widely regarded as a key opinion leader in neurovestibular medicine, we are honored to have him here to set the foundation for today's discussion. Welcome, Dr. Anirban. Then we have Dr. Martin Burkhardt, an international expert in neuropharmacology and Vice President Global Medical Affairs at Schwabe, Germany, who will share his insights on some emerging and therapeutic approaches, including 𝗔𝗵761. Welcome, Dr. Martin.
Good evening from Germany.
We are honored to have an esteemed panel of speakers for our today's discussion, starting with Dr. Professor Vineet Banga, Director and Head Department of Neurology at Fortis Hospital, Faridabad, with extensive experience in vascular neurology, stroke, and dementia. And he brings strong clinical leadership, and he will be the moderator of today's panel. Welcome, Dr. Vineet. We have Dr. Professor 𝗂𝗏𝗂𝗁𝗁, a distinguished speaker from IMS and Some Hospital, Bhubaneswar, and consultant neurologist, First Hospital, known for his contributions to clinical neurology and patient care. Welcome, Dr. Chaudhary. Then we have Dr. 𝗕𝗶𝗃𝗄𝗏, a senior neurologist with over 25 years of experience and founder and director of Pragati Nursing Home, with special interest in dementia, stroke, and vertigo, bringing some valuable and real-world clinical insights to the discussion. Welcome, Dr. Vinay.
Thank you very much.
And we have Dr. 𝗚𝗏𝗏 Chatterjee, Assistant Professor of Neurology at the University of Kolkata, with focused expertise in cognition and behavioral neurology, adding a strong academic and research-driven perspective to the discussion. Welcome, Dr. Chatterjee.
Thank you.
With that, we truly appreciate all our experts for joining us here and will share some valuable insights with us. Let us begin today's session. With that, now I invite Dr. Anirban Biswas to share his views on cognition and balance, the hidden neurology vestibular axis in clinical practice. Over to you, Dr. Anirban.
The entire screen has to be shown, no? Here, do it from here. Can the full screen be seen?
Yes, sir, you can. From your laptop, you can full the screen.
Madam, I have to show the full screen. The full screen is not being shown.
Nitin, you have to just click on that full screen option on the laptop below.
But it is showing not the full screen, it is showing in the A mode. That is not what we require. We want to show it Full screen. This is not the full one. Anyway, I think
नितिन, जहाँ पे वो राइट हैंड साइड पे नीचे फुल स्क्रीन का बटन है, आप वहाँ पे एक बार क्लिक कर दीजिए. Yes, correct.
yes, I will.
Yes.
This is don't touch now. Don't touch.
Yes. Okay.
Keep this thing open. Okay, so I hope I can be seen and heard both. Is that so?
Yes, sir, correct.
Great. So my topic of presentation is cognition and balance. So this subject is extremely close to my heart, and as the world believes today, the entire maintenance of balance, adaptation that takes place after a vestibular assault, the vestibular compensatory mechanism, everything is totally and fully dependent upon our cognition, and the cognitive system is the actual place that controls our entire balance. So we will try to give you an overview of how cognition and balance are related. Then the other speakers will take it forward from there. My job ends at just relating cognition and balance. So that is what I'll attempt to do. Okay. So let us get back into the physiology of balance. The physiology of balance is that we have got input systems to the central nervous system. The three afferent sensory systems are the vestibular labyrinths, the eyes and the proprioceptors, which pick up sensory information from different parts of the body and then sends it to the central nervous system. And from the central nervous system, there is an efferent motor output which is directed to the muscles of the limbs, trunk and neck, that gives us the postural stability, and to the muscles of the eyes, which gives us the visual stability. Because the function of the balance system, the main functions that we always discuss is about postural stability and visual stability. So this is how this thing works. What we do not discuss usually is that there is a huge role played by the cognitive system. The cognitive system retrieves similar experiences stored in the vestibular memory and determines the nature of the output. So that is extremely important, because that is what is the crux of how the balance is maintained. The entire thing depends upon the cognitive system. The muscular output, either to the limbs and the trunk as well as to the eyes, is fine-tuned by the cerebellum. But what happens, when it will happen and how perfectly it will happen, that will depend upon the functionality of the cognitive system. So the maintenance of balance works like this. The central nervous system collects information about the static and dynamic position of the body in relation to the ground and the surroundings from certain sensors, that is the eyes, the vestibular labyrinths and the proprioceptors placed in different parts of the body. Then the information from the different senses is integrated in the brain and compared with previously stored experiences. This is the most important thing. That means my brain is picking up information, sensory information, from the three sensory organs, that is the eyes, proprioceptors and the vestibular labyrinths. And when it has picked it up, it is sending it to the brain, and brain is then relating this new information with similar experiences stored in the brain, and by combining them, it decides which muscles to contract, how much to contract, and what should be the most appropriate motor output. So accordingly, from the information collected from the different sensory organs, and after it is compared with previously stored experiences, a very precise, coordinated and accurately timed motor output is generated reflexly, which contracts some specified muscles and restores balance. This is how the balance system actually works. And the question is, where does cognition come in? In the entire thing over here, is a very natural question. How is cognition coming in? Except for this portion, compared with previously stored experiences. If it has to be compared with previously stored experiences, it would mean that whatever my sensory organs are sending to the brain, that has to be retained in the brain, and as and when necessary, that will have to be retrieved from the vestibular memory, such that I can make the best use of the previous experience combined with the newly picked up information to make the most appropriate contraction of the body muscle such that my body's balance can be maintained. So this is what. But you see, more than that, there is a lot of other things where the cognitive system comes in. We'll see that. Now, what is cognition? I'm not explaining this for neurologists and ENT person, they know about it, but there will be many other professionals also from the medical side for whom the word cognition is not, they're not very conversant with the word cognition. So what is cognition? Cognition means, the Oxford Dictionary defines cognition as the action or the process of acquiring knowledge either through the senses or by reasoning or by intuition. Now, to make it simple, we are all used to the word recognition. What does recognition means? Knowing again. If recognition means knowing again, then cognition should mean knowing. That means collecting information and storing it in the brain. That is knowing. So cognition is the process of acquiring knowledge either through the senses or by reasoning or by intuition. So these are the other definitions of cognition. Now, what is cognition? A little more. So cognition is the highest level of mental information processing in the brain and consists of the actions of first acquiring knowledge through the senses of sight, smell, touch, sound, taste, and balance. They are the different senses. It will collect information from there. Then using this acquired knowledge to achieve a desired goal. What is that goal? Past and before reaching the achieving the desired goal, the past experiences stored in the memory are retrieved to contemplate what the future could be and what could be the consequences of the action, and accordingly the most appropriate motor action is executed so that my balance is maintained, I do not fall, and my postural and visual stability is perfect. So this entire process of acquiring knowledge and then using the acquired knowledge to achieve a desired goal, which in our context today is maintaining postural stability and visual stability. So this is how the thing works. So this entire process of acquiring knowledge and then using our brain to make the best use of it, this is cognition. This is what we mean by cognition. Now, so cognition is collecting knowledge and then using it in different formats, and it involves what? It involves, see, these so many things. It involves memory, as you see over here, memory, then attention, it involves thinking, it involves reasoning, and it involves decision making. So it is a mental faculty by which the central nervous system acquires and processes information received from different sensory systems. So this is what is cognition, and this is extremely important in the maintenance of balance. Each of these components, memory, attention, thinking, reasoning, and decision making, is instrumental in maintaining balance, not only in health but also in disease. We'll come to that. How does that work? So what is the relevance of cognition what is the relevance of cognition in balance? Now, is there any role of cognition in the maintenance of balance and in vestibular compensation? Do balance disorders jeopardize cognitive function and vice versa? That means, do cognitive disorders also jeopardize balance? And number 3 is, does improvement of cognitive function help in restoring deranged balance function? The answer to all 3 is yes. There is a definite role of cognition in the maintenance of balance and in vestibular compensation. Yes, the balance disorders jeopardize cognitive function, and cognitive impairment disturbs balance function, and yes, improvement of cognitive function helps in restoring deranged balance function. So the answer to all these three questions is yes. In the limited time that I have, I'll try to explain why am I saying so. So the components, let's go into components of cognition. Cognition consists of perception. What is perception? Perception is collecting information. Then comprehension, that is understanding and making sense of the collected information. Then memory, that means storing in memory and retrieving the necessary information from my vestibular memory as and when required. Then attention, that means focusing full mental attention, because without paying mental attention you will not be able to maintain balance. We'll come to that part again later on. So I'll explain this part, why attention, which is a major part of cognition, is very important in maintaining balance. Then the next one is reasoning and judgment. Reasoning and judgment means evaluating and making decisions. Evaluating what? Evaluating the information that I have obtained, filling in the gaps, and then understanding which would be the correct decision. And lastly is problem solving and execution of an action. That means applying knowledge and taking the requisite and the most appropriate action. In our case, when we are talking about balance, what is the execution of an action mean? Execution of an action means maintaining and gaze stability, postural stability, and all the other things that are concerned with balance. So this is what. So we will have to remember this thing, that components of cognition include perception, comprehension, memory, attention, reasoning and judgment, and problem solving and execution of an action. The entire maintenance of balance and the process of vestibular compensation depends upon these 6 parameters. So this is extremely important. This is not much discussed in meetings, and we always try to focus only on the vestibular labyrinth and the two vestibular and the two brainstem reflexes, that is the vestibulo-ocular reflex and vestibular spinal reflex. But this is misleading. Our actual balance is maintained by the cognitive system, which takes place high up in the brain, in the highest echelons of the central nervous system. So this is what we are trying to impress upon today. So what are the components of cognition? See, this slide I'll keep on showing you over and over again, not doubting your cognition, but the point is that this is our take-home message. So this is what we need to understand. So what are the components of cognition? I'm repeating again: perception, comprehension, memory, attention, reasoning and judgment, and problem solving and execution of an action. Now there is wide individual variation amongst the different components of cognition. If 6 people are there together, each of these different people will have a different perception, different comprehension, different memory, different levels of attention, different levels of reasoning and judgment, and different faculties for problem solving and execution of an action. So cognition, all these different 6 parameters of cognition differ from person to person, and there is a wide individual variation. And this is the basic reason why for balance disorders, different people respond differently. They are having the same problem, but somebody will come and present it to you in a different formats. Their feeling will be different, and the response to your treatment, whatever treatment you are doing, that will also differ from person to person, because the balance is controlled by cognition, and there is a wide individual variation amongst the different components of cognition. Okay, so let's pass on. See here, what are we seeing? There are 3 persons standing at a traffic crossing. So all of them are having the same visual, vestibular and proprioceptive inputs. So for all these 3 persons, the visual, vestibular and proprioceptive inputs are the same, but their balance will be different because they perceive the input differently. Like how much this old person is perceiving from the proprioceptive senses, how much he is perceiving from the visual senses, and how much he is perceiving from the vestibular labyrinth is different from what this young lady is perceiving from the proprioceptors, from the vestibular labyrinth, and from the eyes. So for all these three parameters, these three individuals are perceiving these three inputs, visual, vestibular, and proprioceptive, in their own different ways, because there is wide individual variation in all the different components of cognition. We'll see this just now. See, this is in a class. The class teacher has given these 12 students 2 pages to read from a book, and then after 10 minutes, or say after 15 minutes, has asked questions. Now somebody has got 3 upon 10, somebody has got 10 upon 10, somebody has got 8 upon 10, somebody has got 2 upon 10, somebody has got 7 upon 10. Why? Because all of them have had the same input, the same 2 pages, all of them have seen for the same amount of time. But how much each one has been able to perceive and store in the brain from those 2 pages, and when the teacher asks the questions, then how much they have been able to retrieve from the brain to answer these questions is different for every person. So the power of perception is different in different persons. And what is this perception? It is the process of acquiring information from different sensory organs to construct representations of the external environment. So what is the function of the sensory inputs? They interface us with the outside world, and how much information I am being able to collect, how much information I am being able to store in my brain, and when required, how much information I am being able to retrieve from my brain will vary from person to person. And that is the reason why different persons have different balances. We'll see that again. So next parameter of cognition is comprehension. What is comprehension? Comprehension is the way by which we first understand and interpret what is happening, then we relate and connect with the different parameters as you see over here, and lastly conclude and respond to this spelling is wrong, it should have been respond, not conclude and represent, conclude and respond to that sensory stimulus. So that is comprehending. So comprehending consists of 3 parts. One is understanding and interpreting the information acquired through perception, then relating the perceived information, that is the perceived new information, to existing knowledge which is already stored in our memory, mixing them up so that I can take the most appropriate decision, and lastly drawing conclusions about the status of the external world. In the context of balance, about how stable is my ground, how stable is my surroundings, and how stable is the spatial orientation. So that is what is important. So cognition transforms sensory information into meaningful understanding and guides our decision and action. When we come to the part on how this is related to balance, we will see how the entire balance system is fully dependent upon cognition only and nothing else. Next is remembering, that is memory. What is this? Memory allows us to store experiences and retrieve them when needed, helping us to adapt, learn, and function effectively in our daily life. So memory is an active mental process of storing and retrieving sensory information to make better use of the newly acquired information and then use it later for future actions. When I will be in a similar situation, I will have to remember that how my balance system used my proprioceptive, visual, and vestibular inputs to get the best possible motor output. So that is about memory related to the vestibular system. Next is reasoning. What is reasoning? Reasoning is applying knowledge to reach a logical conclusion. So reasoning is the application of knowledge and logic to deduce a meaningful conclusion and to make a informed decision. It consists of 3 steps. First is analyzing the information, examining the facts, and identify what is known. make connections, use what I know to figure out what to do next, and lastly, draw conclusions, that is, arrive at a logical conclusion or a solution. So this is reasoning. Next is judging. So to maintain balance, judgment becomes very important. So judgment means judging is the mental faculty of evaluating information, assessing the evidence that is there, that has been collected from the different sensory inputs, and then drawing conclusions to gauge and to predict the outcome of any contemplated action. Like here, this boy is contemplating and the boy is judging, would it be safe to jump over the drain, or will I fall in the drain trying to do so? So this is judgment. It is gathering evidence, assessing options, and lastly making a decision. So to choose the safest and the most appropriate action. Judging helps us to evaluate information, weigh risks and benefits, and then decide what is best before we take the action. Next is focusing mentally. That is also a very important part of cognition, very important for maintaining balance. So focusing mentally is the ability to concentrate mental energy on a specific objective, target, or the stimulus. Next is problem solving or execution of an action. So this is the last part of cognition. So what is it? It is overcoming obstacles and taking effective steps to achieve a desired goal. Here the desired goal is to maintain postural stability and visual stability. So how does this work? Problem solving or execution of an action is the mental faculty of overcoming obstacles and accomplishing the desired objective, and it works in 4 ways. First is identify the problem. Next is plan the solution, think of possible strategies, take the action, put the plan into practice, and then evaluate the outcome, that is, check results, make improvements, and what is most important, store it in the brain so that later on I can use it as and when necessary. So now what happens in cognitive impairment? In cognitive impairment, all these things fail. So in cognitive impairment, what happens is that the thinking process is not working, the reasoning is not working, the learning process is not working, the problem solving ability is not perfect, decision making is imperfect, memory is not working. So when that happens, that is what we call cognitive impairment. So cognitive impairment causes intellectual disability, which is manifested by decline in mental abilities, that is suboptimal performance in the domains of memory, thinking, reasoning, learning, decision making, and problem solving. So dementia and cognitive impairment is what we call cognitive impairment, and in dementia and cognitive impairment, our balance declines. Balance is in poor shape whenever the patient has got dementia and cognitive impairment. You will see, I'll show you evidence later on if time permits, that 60%, more than 60% of patients who have any vestibular problem, all of them, 60% of patients have clinical evidence of balance of cognitive decline, and that 60% have got clinical evidence. The other 40% have got subclinical evidence, which means that anybody having a balance disorder would also have some amount of cognitive decline. This is something which all of us have to keep in mind, and to improve balance, cognition has to be improved. So cognition involves a lot of things: thinking, focusing mental attention, creation and storage of memories, retention of the memory, learning, and logical reasoning. So all this is important for maintaining balance. We'll see that how. So this is all about cognition. Now we go into, so what happens in cognitive impairment? There is cognitive impairment which leads to decline in mental abilities, which leads to intellectual disability, and there is, at the end, there will be advanced, in the advanced stage there will be dementia, that is advanced cognitive impairment. In all your balance disorder patients, you'll have to search for this. This will be there. You would turn a blind eye to it. You'll be missing the cognitive impairment which is there in most of your balance disorder patients. So how are dementia and cognitive impairment linked to vestibular system? Let us see that now. So we have talked about how balance is maintained. Now let us see, and we know that what are the 6 components of cognition. So let us see how that applies to the balance system. So what is in the physiology of balance? What did we understand? That in the physiology of balance is all about understanding, that means acquiring knowledge of the ongoing reality through the visual, proprioceptive and vestibular systems. So what is that? That is perception. Perception is one of the most important components of cognition. Then the second thing is establishing a coherence between these different sensory inputs and by comparing it with the previously stored experiences. So that is comprehension and memory, which again is an important part of cognition. Then the third stage is integrating the inputs in the brain to comprehend the stability of the ground and the surroundings, and that is done by logical reasoning and judgment, which again is a important part of cognition. And lastly is executing a motor action based on the integrated inputs to maintain stability and to prevent a fall. That is execution of a programmed response, which again is a part of cognition. So the entire maintenance of balance is actually a cognitive process. Therefore, maintenance of balance is a cognitive process and is deranged in cognitive impairment and in dementia. Even in mild cognitive dementia, the balance is maintained. There have been a lot of studies where they have shown that the patient has got mild cognitive dementia, has got mild cognitive impairment, but when balance function tests are done on them, they have been shown to have impaired balance function. Then, so maintenance of balance is what? It is a combination of adaptation to the ongoing reality and storing in the brain, that is memorization of experiences learned pertaining to the maintenance of balance, then prediction of the expected response by comparing with previously stored experiences, then innovating newer strategies to maintain balance when similar experiences are not stored in the brain or when contradictory inputs are received by the brain. I will not go into the details of giving you examples for it, but one small example can be something like this, that supposing you are driving a car and at a traffic crossing you are stable in the car. You find that the other cars have started moving. When you find that the other cars have started moving, you are either telling the brain that the visual world is moving, but you are sitting stably in the car. So your proprioceptors are telling the brain, so no, nothing has happened, everything is stable. So whom to believe? Whom will the brain believe? We have got a very smart cognitive system which tells us how much weightage to give to which particular information, that the brain has received, and the brain acts on it. So that is cognition. So these are all cognitive processes, and hence these are deranged in cognitive impairment and in dementia. So now coming to vestibular compensation, that is the mechanism to restore balance after vestibular damage. It acts by 3 ways: by adaptation, which is a learning process by which the balance system relearns the skills of gaze stabilization and maintenance of erect posture; compensation, which is again a learning process by which the balance system learns how to use visual and proprioceptive inputs to use them more effectively to compensate for the defective vestibular input. That means it knows that my vestibular system is not working properly, so I must now put more weightage on the proprioceptive input and the visual input. So that is compensation. So what is that? That's a learning process, and habituation is also a learning process. So the entire process of vestibular compensation is learning and relearning. And what is learning? Learning is a cognitive process. So as vestibular compensation is a learning process, it is dependent on cognitive skills. Hence vestibular compensation is deranged in dementia. So maintenance of balance and process of vestibular compensation involves learning and relearning. That means acquiring knowledge on how to make the best use of the available inputs, which is perception; evolving strategies, that is reasoning, decision making after retrieving past experiences which is stored in the memory; on how to stay erect and prevent a fall in any given situation. So that is again cognition. And lastly, achieve a goal by contracting some body muscles. That means executing an action both in health as well as when the balance system is dysfunctional. Each of them is a cognitive process. Hence, they are deranged in cognitive impairment and in dementia. Okay, agreed with this? So again, this is the same slide I'm showing over and over again. So components of cognition is perception, memory, attention, reasoning or judgment, and problem solving and execution of an action. So where do they come from? All these are linked to the cortex, hippocampus, limbic system and the amygdala, not to the vestibular labyrinth and the brainstem. They are not linked to it, but all our investigations, all our medicines, everything in balance disorders is targeted to the two brainstem reflexes, vestibulocular reflex and vestibular spinal reflex, and not to this portion which is actually controlling balance. So we have to focus our attention to the cortex, hippocampus, limbic system, and the amygdala, because the symptoms of vestibular, all the vestibular symptoms generate from these places, not from the vestibular labyrinth and the brainstem reflexes. We'll come to that later on. So some cortical and subcortical structures are bidirectional neuroanatomical connections. Bidirectional. Remember, it is a two-way connection. Connections to the vestibular nuclei and show degenerative changes in peripheral vestibular disorders. The opposite is also true. In degenerative changes in the cortical and subcortical structures, there is peripheral vestibular damage, and vestibular symptoms may be generated even if there is no peripheral vestibular lesion. So this is where we have to turn our attention to. So cognitive impairment leads to balance disorders, falls and fractures, and poor quality of life. And this is where all of us should turn our attention to. So the functions are linked to cortex, hippocampus, limbic system, and amygdala. So as you said, these components are supported by key brain structures. The vestibular system is reciprocally connected to all these organs and is impaired in disorders of the balance system. And due to the reciprocal connection, the opposite is also true. That means in disorders of the peripheral vestibular organs, the higher centers get affected, and in disorders of the higher centers, there will be vestibular symptoms. It's a two-way relationship. So this is what I'm wanting to tell you. That means cognition and balance, there is a reciprocal connection. It may appear surprising to us, but then that is exactly what happens. Sorry. So cognitive decline leads to balance problems. So in all patients that have cognitive impairment, we have to check the balance, and the other way is also true. In all patients who are coming to you with balance disorders, we have to check cognitive status perfectly and try to treat the cognitive impairment to the fullest level possible, because the entire balance is actually being controlled by the cognitive system. I'll show you that all the different vestibular symptoms that we talk about, all of them are generated by the cognitive system. See, it has been shown that 60% of vestibular patients have cognitive deficits when evaluated. Most of us do not evaluate the cognitive system, and that is why we miss out. 60% have got clinical evidence. The other 40%, at least 30% of them will have subclinical evidence that needs treatment. It needs extra effort to establish that the patient is having subclinical cognitive impairment, and that has to be treated. 30 to 50% of dementia patients complain of dizziness. The others may not be complaining, but if you test the vestibular system, you will find that there is derangement. It has been also shown that only vestibular rehabilitation, not Tai Chi and yoga. Tai Chi and yoga helps in a big way, but Tai Chi and yoga also helps the cognitive part. But vestibular rehabilitation does not do the cognitive part. So that also, only vestibular rehabilitation also helps. So you have to be able to recognize a cognitively impaired patient. This is extremely important. When you see the patient, you have to understand that this patient has got cognitive impairment, how to do the different tests that we do not have the time to go into it. But then in this small time allotted to me, I have exceeded the time, but then this is how we should see and try to look for these changes. So this is a unsteady and a cognitively impaired patient. This is the last portion that I'm showing you, that in neurological practice, the patient comes to the doctor when one or more of the following symptoms. These are the vestibular symptoms. These are the definitions of the Bareilly Society. Unsteadiness is a feeling of imbalance. Vertigo is the erroneous perception of motion. Visual symptoms are perceptions of motion of the surrounding external vertigo. Dizziness is impaired orientation and perception of the surrounding three-dimensional space. And the non-vestibular symptoms are cognitive, functional, and psychic abnormalities. Fear of fall, that is a dreadful feeling of an impending fall. So what is common over here? Feeling or perception. Where does feeling and perception originate from? It originates from the higher centers of the brain, not from the vestibular labyrinths, not from the brainstem reflexes. So vestibular symptoms are just feelings or perceptions, and non-vestibular symptoms are manifestations of cognitive and psychic abnormalities. All are generated from the cortex and subcortex, and are mainly from the neocortex, hypothalamus, and entorhinal cortex, neither in the vestibular labyrinths nor in the brainstem. Neurological symptoms are generated only when cortical structures malfunction or are manipulated, which is possible by aberrant vestibular stimulation only in 25 to 30% cases. Rest are all cortical and subcortical defects. So all vestibular symptoms as perceived by the patient originate in the cognitive system mainly. So we are so it's a continuously evolving process. This adaptation, prediction, innovating, this is going on continuously, and our brain is constantly evolving this system. So what are the cognitive disorders in a vestibular disease? They consist of these 10: short-term memory loss, poor concentration and poor multitasking skills, poor topokinetic memory, poor learning skills, impairment of mental attention, impaired memory in the domain of object recognition, poor skills in spatial navigation, poor memory with numbers, difficulty with arithmetic and reading, and abnormal levels of anxiety and depression. There are enough of evidence, enough of published literature on each of them. If any of you want, I will be more than happy to supply you. So cognitive impairment induces vestibular symptoms, and vestibular disorders induce cognitive impairment. I have rushed through this complex topic, but then my job was this, and to finish it within 40 minutes, I have just exceeded that by a little bit. Okay, so can I stop sharing now, sir?
Thank you so much, Dr. Anirban, for those knowledgeful and engaging insights. And I think it has offered valuable takeaway for all of us. Thank you so much, sir, for sharing those insights. With that, moving onwards now, I would like to invite Dr. Martin Burkhardt to share some insights on the role of EGB761 in cognition and balance. So over to you, Dr. Martin. We'll just display the screen for once.
So thank you for the opportunity to use the next 10 minutes to share with you evidence, mainly clinical evidence, of the role of a specific ginkgo biloba extract we call EGB761 in balance disorders and associated cognitive impairment. So first question is, what could be potential mode of action? Why should a ginkgo biloba extract help in balance disorder? If you go to the next slide, please. It's important to understand that a plant extract, such as a ginkgo extract, is not a single molecule. It's a mixture of about 80 to 100 compounds, all of them that are extracted from the herbal drug. And each of these single compounds interacts with multiple targets. Thanks to the huge advances in analytical technology and biocomputing, now all those interactions have been revealed. And as you can see here in the left side of the diagram, all of those constituents of ginkgo have been analyzed considering their pharmacokinetics, so only those that are absorbed to the body, to their interaction with a multitude of targets, mainly proteins, being enzymes, channels, receptors, or any other protein. And each of these proteins does not work on its own, but it's part of a complex signaling pathway or metabolic pathway. And with the computing technology we have today, we can analyze those pathways. This approach is called network pharmacology. And as you can see in the middle part of the chart, there are a number of signaling pathways within every mammal cell. These are very conserved pathways, and all that are labeled in green here are modulated by this ginkgo extract because of the multiple interactions with many proteins in the cell. So signaling pathways are active in most of our cells, but certainly to different levels with different function in different tissues. And based on the effects on cellular function, the ginkgo extract affects many pathological processes that are involved in brain aging. For example, in cerebrovascular changes, because the extract have been shown to improve microcirculation by effects on both red blood cells and endothelial cells. It has effects on astrocytes, and it has multiple effects on neurons, improving synaptic function, improving neuroplasticity, and helping against neurodegenerative changes such as beta amyloid deposits in the brain. So all these elements can help to improve age-related brain disorders. And based of these data, and certainly a large number of big randomized double-blind placebo-controlled trials, the compound is primarily used for the treatment of cognitive impairment and dementia. In the next slide, I've shown you the essence of all this knowledge, because it would be a different lecture to go through all the data. But the essence is that 𝗔𝗵761 is among the standard treatments for mild dementia. For example, the Indian Psychiatric Society recommends this specific ginkgo extract at a daily dose of 240 milligram as part of a multi-domain intervention for mild neurocognitive disorders. Here in Europe, I am from Germany. Our regulatory agency, the European Medicines Agency, has approved the product for the improvement of age-associated cognitive impairment and for the improvement of quality of life in mild dementia. And from an international perspective, shown in the right part of the chart, the World Federation of Societies of Biological Psychiatry recommends the product for the symptomatic treatment of Alzheimer's disease at the same level as the cholinesterase inhibitors, donepezil, galantamine, and memantine, other products used for the treatment of Alzheimer's disease. But today's lecture is about balance disorder. So let's go to the next slide. The question is, do we also have pharmacological proof of effects that are helpful in balance disorders? And yes, we have. It has been shown that 𝗔𝗵761 accelerates vestibular compensation. This is an animal model in the rat that simulates vestibular neuritis, so sudden loss of labyrinth function in one side. Animals are anesthetized, and then one labyrinth is taken out. And those animals develop a phenotype that is very close to acute vestibular syndrome. So they have nystagmus, they cannot stand upright, they tilt to the side, and this can be easily measured. And as we have learned from Dr. 𝗏𝗏𝗏, yes, there is vestibular compensation, the brain can learn again, and the symptoms decline. And what was shown in this experiment, that if you treat those patients with 𝗔𝗵761, either after the injury, this is the middle bars, or before and after the injury, this is the left bars, vestibular compensation is accelerated by 𝗔𝗵761, probably because of its enhancement of neuroplasticity. Well, this is an animal experiment. We are physicians, we do treat patients. Do we have evidence of the same effect in patients? And yes, we have. In the next slide, I show you a study of patients with sudden peripheral vertigo. So most of them had vestibular neuritis, and they were treated with a standard of care with vestibular rehabilitation. And with vestibular rehabilitation, patients improved over the next weeks. And they were randomized either to add 𝗔𝗵761 or not to vestibular rehabilitation. And you can see also in men, the product accelerates and improves the effect of vestibular rehabilitation. Here shown in posturography, where patients need to stand up, close their eyes, and then the body sway is measured. Interestingly, this effect can not only be shown in acute vestibular syndrome, but also in chronic vertigo. In the next slide, I'm showing you a study in patients with, can you go to the next slide, please? In patients with chronic vertigo, mean duration of disease was 4 to 5 years. Patients were suffering from vertigo. In posturography, here very nicely shown when people were asked to close their eyes, they had significant body sway, and then they received for 4 weeks very intensive vestibular rehabilitation, and patients improved significantly. Yes, the brain can adapt and can learn again. And these patients were randomized either to placebo or 𝗔𝗵𝗏𝗁, and the improvement in sway amplitude was much stronger in those where 𝗔𝗵𝗏𝗁 was added to vestibular rehabilitation. Very important trial, but this trial has been published around 40 years ago. So the question was, can we replicate this finding? And yes, we can. In the next slide, I share with you a recent study conducted in patients with vertigo after stroke or transient ischemic attack that have received standard treatment and after 3 months still suffered from significant impairment due to vertigo. Again, those patients received intense vestibular rehabilitation and 𝗔𝗵𝗏𝗁 or placebo. And as you can see here, after 4 and 6 months, patients receiving 𝗔𝗵𝗏𝗁 had significantly better treatment success. So the combination of vestibular rehabilitation and 𝗔𝗵𝗏𝗁 can be seen as a standard treatment in patients with chronic vertigo. With these data, then, we dared to try this approach in the most difficult to treat patient population. Next slide, please. These are patients with chronic age-related vertigo. So elderly people here, mean age was 75. They do not have a single cause of vertigo, but multiple. They have degeneration of the elaborate organs, they have peripheral neuropathy, they have cerebrovascular impairment, they have visual impairment, they have cognitive impairment, and as a result, really impairing their daily life is chronic dizziness and gait disturbance. So these patients were treated with EGB and vestibular rehabilitations. It's the gray bars here. And we used an experimental new treatment where balance training is added with a belt that gives a vibration when people sway out of the normal position to have an even more intense vestibular rehabilitation. And you can see in both groups, the fall risk significantly improved. But what is important for patients is shown in the next slide. It is the extent to which they are impaired by their dizziness in daily life. And this is in detail captured by a questionnaire, the dizziness handicap inventory. And is shown here, the gray line, 𝗔𝗵𝗏𝗁 and balance training led to a really impressive improvement in dizziness handicap. Treatment effects were even better with adding those vibrating belt to the balance training. And this was very encouraging in this very difficult to treat population. If you go to the next slide, we compared our results, so the improve in dizziness handicap in our studies, both top line with any other studies conducted in this specific patient population. And with the combination of EGB and balance training, we have received better results than any other approach tried before. So yes, we can make significant impact to those patients and improve their daily life. In this trial, this is shown in the next slide, we also measured cognition. What we measured here is a test of executive function. It's called the trail making test. So people have to draw a line as fast as possible around those dots, but they have to switch between letters and numbers. So it's 1A, 2B, 3C. So it's not an easy task. Here patients took around 120 seconds to complete the task, which is a rather poor result. So people really had some degree of cognitive impairment, so none of them was demented. And yes, cognition improved during this trial in the same way as dizziness impairment improved. In the next slide, I will show you a study I like very much because it was a very clever way to test these patients is dual task. Ask them to walk on a line while doing mental arithmetics, for example, counting back in sevens. So this task is quite easy for you, but with elderly people with brain impairment, either they stop walking when they start mental arithmetics or they slow down walking. And in this trial, nicely shown, if those patients are given ginkgo, they perform much better in the double task than when they are given placebo. All of you know that there are plenty of patients where you do all your diagnostics. You look for vestibular function, you look for Meniere's disease, you look for migraine and whatsoever to find a specific reason of vertigo. And there are many patients that are really suffering from vertigo and you cannot identify the specific vertigo. And this patient population was analyzed in the next study conducted by next slide, please. Conducted by an ENT university department in Thailand. So very experienced ENT doctors, really knowledgeable. And they had those patients with acute dizziness vertigo of unclear etiology. So what are you going to do with them? Many physicians around the world use a pragmatic approach and just prescribe a drug that might help. So these patients were randomized to take either 𝗏-histamine or 𝗔𝗵𝗏𝗁 for 12 weeks. And with both treatments, vertigo significantly improved and both treatments were effective alike. But interestingly, during those 12 weeks, the mean number of emergency department visits for vertigo when patients were very concerned about vertigo went to the clinic was significantly smaller with 𝗔𝗵𝗏𝗁 than with 𝗏-histamine. So obviously the product had a clinically relevant benefit for them. So today's take-home message is shown on the next slide. Is that 𝗔𝗵𝗏𝗁 accelerates and enhances the effects of vestibular rehabilitation, leading to notable and clinically relevant reduction in dizziness-related impairment, and as a positive effect, cognition improves in parallel. So thanks for the opportunity to share this data.
Thank you so much, Dr. Martin, to share those wonderful insights on the role of GB761 in cognition and balance. With that, let's take our session forward, and we have a wonderful panel discussion ahead with our esteemed panelists. So I would like to hand over to Dr. Vineet Banga, the moderator of this panel, to take this ahead, sir. Over to you, Dr. Banga.
Thank you very much, Dr. 𝗓𝗏𝗏. We have an esteemed guest on the panel, and I would ask some questions, and I would appreciate the responses. And the first question is that considering available resources that we have at our place, how do you integrate therapeutic options in management of patients who have overlap of balance disorders and cognitive complaints? So I would like to ask Dr. Vinay, sir, if he can put some light on how does he really manage these patients, depending upon the facilities that somebody has in his with him, the overlap that is there between balance and cognition.
Thank you, Dr. Banga. You are asking a very pertinent question. Because this question becomes relevant, we are practicing a different part of India, and every place has different resources. And the place where I work is Bareilly. It's a moderate city. We don't have all those facilities which are there in a metro city. So I have to take into consideration the limited resources which are available with me to diagnose and to treat these patients and to make a balance and to detect a balance between a cognitive dysfunction and vestibular dysfunction. So the most important thing is that I try to take a practical and multimodal approach so that I can utilize maximally whatever the resources available with me. First of all, a detailed history gives the maximum clues whether dizziness is really of vestibular origin, vascular origin, or is related to anxiety. Not only this, history also gives clues whether cognitive symptoms are really true impairment or they are secondary to poor attention, mood disorder, or disturbed sleep. So once I have analyzed these patients, so there are two options. There are non-pharmacological methods and pharmacological methods. The commonly used non-pharmacological methods are the most important and core component is vestibular rehabilitation therapy, is cost effective and feasible with simple guided exercises. Second important component is to involve patient in cognitive engagement in form of like memory exercises and mental stimulation. This helps in improving their cognition and indirectly improving their balance. And the most simplest way but difficult to persuade to patients is lifestyle modification, which really makes a uh, denting effect on these patients, is improvement of sleep hygiene. Patients should do regular physical activity. They should be properly hydrated, and whatever the risk factors they see for fall, they should try to prevent those strategies. These are discussed with these patients. Not only this, we have to see if the patient's symptoms are predominantly being plagued by anxiety and somatization, then these parts should be taken care into. They require counseling and reassurance, sometimes even from psychologists. So, coming to now to pharmacological part, there are limited options we can try with this. One of the options which already has been discussed in this webinar itself is EGB761, which have a dual benefit of action on cognition as well on vestibular compensation, which has been proved in various trials. So I use it for a longer period for about 6 months, and that 240 milligram doses. Besides this, if patient is having vestibular symptoms which are troublesome for patients, I use vestibular suppression drugs for an initial period of 1 to 2 days or at the max 3 days, and rest of the period these are avoided and non-pharmacological methods are used. If patient is overwhelmed by anxiety or sleep disturbances, of course conventional anxiolytics can be used, and sometimes even natural resources like options like Selexon can be used. If a patient is having vascular risk factors, elderly patients having diabetes, blood pressure, that should be monitored. And for patients suffering from multi-infarct dementia or a small vessel disease, if required, these patients can be kept on statins and antiplatelets. So these are my modalities to these patients at my place, and I to utilize it the most possible.
Is in one country, so what we use probably in metros could be very different from what you use in your setup. And I belong to Ujhani, which is very near to Bareilly, so I can very well appreciate the services that you bring to the society in general. So the next question is to Dr. Atri. Dr. Atri, how do you assess the relationship between cognition and balance in patients, especially when they come for OPD visits? So how do you assess the relationship?
Thank you for the question. Generally, I have a memory clinic where in Safdarjung, most of my patients have cognitive impairment due to various causes. And there are ways to separately assess cognition and balance during the clinical examination, and there are some tasks which assess them at the same time. So at the baseline, I would generally assess cognition using a cognitive screening battery like the Montreal Cognitive Assessment Test or the mini mental state examination, and then combine that with the neurological examination. But also to quantify balance, I generally use the Borg balance scale. The Borg balance scale has been quite useful because it doesn't need any instruments and it can give a longitudinal view of how the patient is doing in terms of balance. Another very useful test that also doesn't require any instruments. Dr. Martin showed that test, that is the dual task. You can just ask the patient to walk a fixed distance, for example, 10 meters, take that time, and then you ask the patient to perform a mental task. There can be different kinds of tasks and different tasks have different effects. So one of the common tasks that's used is a serial subtraction task. So you can ask the patient to subtract 7 from 100 and continue subtracting 7 while the patient walks the same distance. And you can measure the time taken. In the second phase, the patients with cognitive disorder, milder cognitive disorder, and also associated balance disorder will significantly slow down. And you can monitor this also over time, and you will see the gradual deterioration, and which helps us in predicting falls also. The other useful tool, again, without using any instruments, is there are a number of scales that measure frailty. So frailty is a concept which combines the cognitive deterioration along with physical deterioration. And generally, it seems that the frailty scores will also correlate very well with worsening of balance and the risk of fall. So that gives us a measure of progression of dementia and cognitive impairment. So these are the tools that I commonly use without any investigations per se, just in the clinic to measure cognition and balance.
Thank you so much, Dr. Atri. That was indeed nice to hear, like the methods that you use in busy OPD practice, especially in Safdarjung, I think, which has a very busy neurology OPD. Thank you so much. My next question is to Dr. 𝗤𝗍𝗄 Dr. Prakash, how do you manage and should we do cognitive screening tools, and should we use them to routinely screen patients with chronic vertigo? And what is more sensitive, especially in the early stages, bedside test or any neuropsychological assessment that you use in your practice routinely?
Yeah, thanks for the question. As we know, in previous presentation, the cognitive impairment, vertigo, these are the things which are most commonly associated. And especially, we should assess a cognitive impairment in case of patient present with vertigo, especially in the elderly patient who present multiple times to the OPD clinic, presented with recurrent vertigo, chronic vertigo, elderly patient, and there is no visible, there is unexplained causes of the vertigo, and repeatedly they are resistant to the common therapy of the anti-vertigo treatment. So in these cases, we should assess cognitive assessment should be done properly to assess any the cognitive impairment or not. So basically, the vertigo, we should do a bedside vestibular testing test. Like commonly we are using hint that head tilt test, nystagmus, skew test. These are commonly tests done in the neurology OPD or ENT clinic, especially. For us to know for the cognitive impairment, commonly we are using MOCA or MMSE or any cognitive assessment tools commonly using in our neurology and psychiatry OPD. So these are the bedside tests we should use, should be used. So as there is a strong evidence that chronic vestibular dysfunction linked with cognitive impairment, particularly the spatial memory, attention, executive function, and also other domains of the cognitive impairment. So, in case of old age, recurrent chronic vertigo, no visible causes or no, there is unexplained causes of the recurrent vertigo, especially the resistance to the anti-vertigo treatment. In those cases, we should assess the cognitive impairment particularly and thoroughly.
Thank you, Dr. Prakash. That indeed was great to know. Dr. Vinay Agarwal, sir, if you can tell us, when do you really start actively assessing cognition in patients with the vestibular dysfunction? And do you do it routinely for all the patients, or there is a inflicting point when you decide, okay, now I want to assess cognition in this particular patient? And also, what clinical cues actually prompt you whether we should evaluate the patient for cognitive function or not?
Thank you, Dr. Banga. So, as already been discussed by Dr. Anirban sir, that there is a bidirectional relationship between balance and vestibular system. So, I try to approach it the same way, and I have to look into patients, specifically which patients should be screened and looked into for either cognitive dysfunction, who are already in vestibular dysfunction, or patients who are having cognitive dysfunction, they should be looked for vestibular dysfunction. Though, as already been discussed by Dr. Anwar sir, majority of these patients, they have underlying either cognitive dysfunction with vestibular dysfunction or vestibular dysfunction with cognitive dysfunction. So, specifically, if a patient is presenting to me with chronic or recurrent vertigo, that is a vertigo which is lasting for more than 3 months, and the patient is not responding to standard therapy, in this group of patients, I would like to see specifically for cognition. And when there is a disproportionate disability, means the imbalance which the patient is having is not matching with the vestibular dysfunction which this patient is having. Or what if the test suggests that amount of vestibular dysfunction or disability this patient should have, but it is more, then I screen these patients for assessment of cognitive dysfunction. Not only this, any elderly patient, that too specifically having vascular risk factors or risk factors for stroke especially, I assess these patients for cognitive dysfunction, whether they are having associated cognitive dysfunction or not. Besides this, there are few patients who present with complaints of like brain fog functions, poor attention, slow thinking, and these patients definitely specifically require cognitive function checkups. And if a patient is having vestibular symptoms which are not compatible with gait instability or frequent falls, these patients also require cognitive function evaluation. In OPD base, most of the time I prefer to use MMSE to evaluate these patients for cognitive function. Coming to the patients who are having a cognitive function, which particular group of patients I suggest I look and I screen for vestibular dysfunction. Again, there are few groups of patients. If a patient is having unexpected or unexplained balance and falls with a minimum cognitive decline in these patients, if a patient is having spatial disorientation, that is, he is getting lost in familiar places In these patients, I prefer to test vestibular dysfunction. Or if a patient is having gait apraxia, there's a cautious gait which is not being fully explained by the level of cognition which the patient is having. Besides this, if a patient of cognition dysfunction, if he is having episodic dizziness or head movement induced symptoms, especially in this group of patients, not only this, if after evaluation, if a patient of a cognitive dysfunction with disability to walk is not, his cognition is not improving with standard therapy, then I would like to into vestibular dysfunction. So these are the specific pointers which there I prefer to look into. But as Sir had already said, practically every patient, either with cognitive dysfunction or vestibular dysfunction, should be evaluated for vice versa.
Thank you so much, sir. Dr. Atri, my next question is to you. What are the common neurological conditions that you encounter in your practice which has both cognition as well as balance involvement?
Patients come to me with cognitive impairment. And not if, but when. So to balance at different stages. So for example, generally Alzheimer's disease patients, the first sign of balance disorder appears when the disease has reached its moderate stages. So approximately when you see MMSE coming down to approximately 10. So you expect that these patients either they will complain, and at other times they will not complain, but they will suffer the first fall by that time. In contrast, those with vascular cognitive impairments, they are much more likely to fall and to complain of balance disorders or become unsteady at a much higher level, even if they don't have a paralysis, even if they haven't suffered a clinical stroke, because cerebral small vessel disorder is very common in my patients, and it's common. It affects the posture network at multiple levels, at both the levels of brainstem and cortex. PSP, progressive supranuclear palsy, we all know, is a disorder where patients start falling early. I'll just mention another disorder which causes a sense of unsteadiness, which is not that common, which is called posterior cortical atrophy. Now, as Dr. Biswas mentioned, that there is a problem of perception of the 3D space. Now, this is the core deficit in posterior cortical atrophy. So these patients they might fall or they may feel imbalanced, not because of the motor deficits or the coordination deficits, but because they have a problem of the 3D space. They might perceive the 3D space as shifting constantly, not fixed in space. So, and each of these patients again will have slightly different complaints in terms of balance and slightly different rates of falls.
Thank you so much, Dr. Atri. The next question is to Dr. Sujay Prakash. Dr. Prakash, in your practice, whenever there's a patient who has coexisting cognitive and balance disorder, so must be using some medicines, some pharmacological agents, and which one do you prefer, and how do you mitigate the side effects of using them together, their interactions together? So how do you go about it? Dr. Sujay Prakash, you are mute.
Patients who are presenting with vestibular dysfunction, vestibulopathy, vertigo, coordination imbalance, along with some sort of cognitive impairment, cognitive decline. So in that case, to treat those patients that requires a balanced treatment with symptoms targeted treatment, and especially those medication, those drugs which are cognitive sparing pharmacological agents. So mainly for the symptomatic treatment, anti-vertigo treatment, all of are very familiar with those drugs. like 𝗏-histine, meclizine, synergine, diphenhydramine. So these are commonly used in OPD basis, those patients presenting with the vertigo or any type of coordination. But as you know, in those drugs, there is some sort of side effect, like starting from the GI side effect, headache, and even sometimes I've seen the patient with vertigo. If you will suddenly start the 𝗏-histine or synergine, patient will tell that my vertigo and my head drilling sensation is increased. Some suddenly also I have seen. 𝗏-histine synergy also lots of sedation effect, and chlorpromazine, that is some sort of extra pyramidal effect. So sedation, GI side effect, headache. So these are the common side effect. Generally, we are familiar with those drugs. And for the cognitive impairment, we all know as donepezil, memantine, rivastigmine. So there is also some sort of side effect like cardiac side effect, bradycardia, same GI side effect, nausea. But memantine useful in the severe to moderate type of cognitive impairment or dementia. So although useful along combination with donepezil memantine combination, but still the side effect like dizziness, confusion, and other sedation, abnormal behavior. So these are the common side effects we generally encounter in the day-to-day practice. And as we discussed previously, like 𝗔𝗵761 ginkgo biloba extract, which have dual mode of action in case of vertigo and also for the cognitive impairment, also a neuroprotective agent with some microcirculatory effects. So, although very useful in case of vertigo present with some sort of cognitive impairment, so should use properly and with cautious also, and be careful about the GI side effects and headache and some type of nausea type of side effect. I have seen prescribed many patients with 𝗔𝗵761 nausea and GI upset is major side effect to encounter regularly in the OPD basis. So as all the cognitive impairment molecules, anti-vertigo molecules, so those drugs are as a lot of side effects. So those drugs should be given or should be monitored properly. Always it's better to start from the low dose, gradually can increase the dose. That is one of the can use in our OPD practice. Some also clinician they prefer to start high dose and then gradually taper the doses. So depend on the patient profile, patient side effect, patient tolerating capability, patient compliance. So you should use that anti-vertigo and neurocognitive drugs precociously and with gradual monitoring.
That also brings me to notice that 𝗏-histine, I think, is one of the most commonly abused drug in practice, because anybody who says it is chakkar in India, he or she will receive 𝗏-histine. And sometimes this is not actually chakkar, this is not actually vertigo, this could be something else. This could be balance disorder, this could be postural hypotension, this could be sensory ataxia, this could be anything. So this could be frontal gait disorder, Parkinson's plus. But the first thing that many of is, as soon as the patient says that he has chakkar, he'll go ahead with prescribing 𝗏-histine without at times ascertaining that it can cause cheese reaction with certain molecules and all of that. So thank you everybody. Thank you Dr. Vinay, Dr. Chaudhary, Dr. Atri for taking active part in the interaction. Over to you, Dr. Muskan.
And I would like to thank everyone. Yes, Dr. Vinay.
Yeah. Can I ask a question to Dr. Martin?
Sure.
My question is, like, suppose we use 120 milligram per day of 𝗔𝗵761. So how long it will take to have a therapeutic effect, visible therapeutic effect, or should we always use 240 milligram?
So the recommended dose has evolved over the decades. So some 20, 30 years ago, physicians here in Europe typically used 120 to 160 milligram per day. And then over the last 20 years, it became standard to use it 240 milligram per day. And this was in detail assessed in studies on cognition. In mild dementia, it was very obvious that the 240 milligram was more effective than the 120 milligram. So now the standard recommended dose is the 240 milligram. In balance disorder, there are not so many trials. So some of the older trials used the 160 milligram, but the newer trials also used the 240 milligram. And because of the good tolerability, the excellent tolerability, we typically recommend the 240 milligram. In balance disorder, as I've shown from all this trial, it was used as add-on to vestibular rehabilitation. And so it should be used for the times that you typically recommend vestibular rehabilitation. So in those trials, it was 4 weeks, 8 weeks, 12 weeks, where patients were recommended to do their balance exercises.
Can I also add a little bit to Dr. Vinay's question?
Yes.
Sure, sir. Yes, sir.
So see, in my practice, I use 240 milligrams daily and never for less than 3 months. 3 to 6 months is what I use on a regular basis. And since my practice is limited to neurotology only, I see only balance disorder patients. Other patients don't come to me because for the last 40 years, I've been seeing only balance disorder patients. So I do not get any other patients. So in my practice, in most of the patients, nearly all patients, we do a gross evaluation of the cognitive function also. We do some of the tests like MMS, MoCA, etc. And see, with training, I have paid psychologists in my clinic also to assess these patients. And when we find that yes, there is some amount of cognitive dysfunction, how do we assess it? In most of the patients, we do the 𝗓𝗃 test, then this NAT test, that means the navigational ability test. We do this regularly. When Dr. Otri was over there, I have had the good fortune of working with Dr. Otri in Institute of Neurosciences in Kolkata. Then he ditched us and he left Kolkata, and then we were left in the lurch. But when working with Dr. Otri, we used to share so many patients with cognitive dysfunction, and a lot of it I have learned from him. And so, from that I became convinced that we have to look for cognitive disorders. We do the 𝗓𝗃 test. These are very simple tests. Then we ask they do the test which Dr. Otri and Dr. Martin also mentioned. That means walking in a straight line, doing mental arithmetic. So, and then by looking at the patient also, we can understand that if the patient dress is not, patient may be wearing a proper dress, but the buttons are not proper, the belt is at a different place, the coat is a little bent. So from that, the patient's countenance, you can make out also that yes, this patient is possibly having a cognitive impairment also. The patient has put the belt but has missed 2 or 3 things. You understand that there is a cognitive impairment. But if there is evidence of the patient being careless about his body, about his countenance, you can think about cognitive impairment. And we do this specific test when we have used. See, we also do vestibular physiotherapy and this occupational therapy, yoga and all. We do most of these things. We do a multimodality treatment. In fact, in a new clinic that I've started in Delhi, we have all these facilities for a full-time psychologist in our Vertigo clinic. We also have parts of it in our clinic in Calcutta. But then this is it. We find that when we have put the patient on long-term EGB 761 for more than 3 to 6 months, their cognitive power, as we can understand from the navigational ability test, by the 𝗓𝗃 test, they improve. 𝗓𝗃 test is nothing. You just have a board in which there are there are 8 dices. You touch them one by one and ask the patient to repeat and do it. By that, you can test the patient's spatial, the visual spatial cognition. So these are the things which are not routinely done. People practicing Vertigo, they only run after the vestibular function tests and all. The vestibular system contributes very little in the maintenance of balance. In our day, it is all published literature that it has now been shown that to maintain balance in our day-to-day life, when we are walking or standing on a hard surface in a lighted area, more than 70% of the input for the balance system, it comes from the proprioceptive senses. So when it is not from the vestibular labyrinth, so it is coming from the proprioceptive senses. What should we test? We test for the integrity of the dorsal column by doing tests like biothiopsymetry. We test all these things. Why is the patient not being able to pick up adequately from the proprioceptive system? Must be the patient must be having a cognitive problem. The perceptive power is less. So we have to think on these lines, and we have to widen our horizon and to think about how the cognitive system is also involved. And if you take it from me, I am, of course, nobody in this thing, but I've been practicing on Vertigo for a long time. I can vouch that if you take care of the cognitive system, you will be able to do a lot of benefit to your balance disorder patients. All balance disorder is not vertigo and head spinning. Most of it is dizziness, unsteadiness, etc., with perfectly normal vestibular labyrinths. So when you think about these lines, we have to think about the proprioceptive system, about the cognitive system, and all the other things. And some lateral thinking from our side is also necessary. I do not know whether I've said more than I should be saying, but the point is that I wanted to share my experience, and I know all of you so very well, but at a personal level also. So that is why Dr. Vinay is of course very close, and Dr. 𝗔𝗂𝗂𝗍, I know him, but then have not interacted with him. Dr. I also know very well, so that is why I thought of sharing the experience. Thank you.
Thank you, sir. Sir, my question is to you, sir. One question is like this cognition and balance, of course, they are interrelated.
Yes.
But sir, where the age plays a role, like can we divide a line? Likewise, one of the few of the papers which I was reading, the younger age, if patient is having vestibular dysfunction, the processing speed, spatial disorientation, they are not much disturbed in patient with vestibular dysfunction. Whereas the elderly patient, so is there a cut line of age where we expect that the cognitive dysfunction plays a significant role?
Yes. See, in aged patients, most aged patients will have some amount of cognitive dysfunction because cognitive function declines with age. We are not evaluating the cognitive system by our tests on a routine basis. So a lot of it we are missing out. But with aging, both the balance system's function deteriorates as well as the cognitive functions deteriorates. So no wonder aged patients have a mix of balance problem with cognitive problem, and they perpetuate one another, and the patient becomes more and more unstable. So in these patients, of course, we will have to treat the balance disorder in case it is a vestibular problem. But it has now been shown by different researchers that in an aged patient, it is not that the vestibular function deteriorates so much. It is more the central degenerative changes that is related to aging that contributes more to the balance problem than the dysfunction of the vestibular labyrinth. And there are a lot of studies which have established that, and it has been shown. In my presentation, it was a pretty long presentation that I did, but this subject of cognition is so huge that those slides were there with me. I could not show those slides where it has been shown that different studies it has established that in aged patient the imbalance is more due to a cognitive dysfunction rather than disorder of the vestibular labyrinth and the vestibular system. So the cognitive system has to be looked into, and we need many more of Dr. 𝗏𝗏𝗏. I do not know, but his position now. But when we were working in Institute of Neurosciences, he was heading the cognitive neurosciences division, and so it was so wonderful working with him and learning from him. So that is what is there. Possibly he is also in charge of the cognitive department in Safdarjung now, that I do not know, but there when he was in INK, he was in charge of that cognitive neurocognitive division. And so that means many people do have a cognitive impairment. Otherwise, how was the hospital paying him? So then he had lots of patients in the department who had cognitive disorders, and he was seeing only cognitive disorder patients only. So it is not that rare. It is pretty common. I do not know about others, but he was doing cognitive neurology basically, and is running the department excellently.
Thank you, sir.
Okay, so I believe we have had enough of cognition today, and we now need to go incognito. We need to go incognito now.
Correct, sir. So with that, I think we are coming to the close of today's session, and I would like to extend my heartfelt thanks to all of our esteemed speakers for sharing, your valuable perspectives and enriching this discussion with an interactive Q&A at last. And I think your insights have truly helped us deepen our understanding of the relationship between cognition and balance and its significance in clinical practice. So thank you so much, everyone, for joining and sharing your valuable insights. Thank you so much.
Thank you so
Thank
much
you.
for organizing.
Thank you. Bye-bye. Good night.
Good night.
Bye, sir. Thank you, sir.
Thank you very
Thank you.
much.